Yeah. Confirm you can see my screen?
Yes, Dr. Zuriel, we can see it.
Fantastic. What we will do today, we'll discuss schistosomiasis. We will create an avenue on how and when we can discuss ischemic bowel disease, but largely you'll also have to do some homework on it yourselves. And tonight you study ischemic bowel disease. I know this is very fresh in your memory from parasitology. Importantly, we need you to know the types of schistosomes and their distribution geographically, to know the pathology, basically morphology, habitat, life cycle, mode of transmission, and the disease process in the host or in the human. Understand the clinical features of GIT schistosomiasis, and understand laboratory diagnosis of schistosoma parasite. So which ones are you going to do, which tests to be able to pick? And then we're also supposed to touch on GIT TB, I think. This is how we grew up, you know, back in the village where the real life exists. You take your water, you take a shower, you take a bath, not a shower, you take a drink, you take the rest for cooking. And the guys upstream are also susuing and poo-pooing the same water. The cows and the animals and the wild beasts are sharing the same glass. A little bit on the history. Schistosome eggs were found in ancient Chinese and Egyptian mummies by Sir Armand Rufer in 1910. And the first species of Schistosoma hematobium were discovered or described. Schistosoma japonicum, named by Fujiro Kasurada, who is a professor of medicine at Okayama Medical School in Japan. And then we have Schistosoma mansoni, that was discovered in 1907 before the Egyptian discovery. Finally, now we still have Schistosoma mekongii, officially named in 1978, and intercalatum, officially named in 1934. So that's a history of the schistosomes. Incidence. The intestinal schistosomes. Mansoni is more prevalent within the tropics. We have Africa, Middle East, Caribbean, Brazil, Venezuela, and Suriname. Japonicum, it's more in Far East. You have China, Indonesia, and the Philippines. Mekongii is a little bit central there. You find it at Cambodia and Laos. Intercalatum, it's in the rainforests of Central Africa. Central Africa. Then you have hematobium, again, Africa and Middle East, that is in the urinogenital system, and we will not touch that today. Global distribution. Yes, global distribution, we have, it's more on the tropics, as we elucidated earlier. We look at the life cycle. The life cycle of schistosomes, we can start at the point where we have We start at this point when we have Saccharia, or we could go to point 1, where you have the eggs either passed in feces or urine. Eggs hatch releasing miracidia in water. Miracidia penetrates the snail tissue, stage 3. From the snail, then we have development of sporocysts in different generations. And from there, you have stage 5, you have the Saccharia that are released by the snail into water, and they become free swimming organisms. There, they're able to penetrate into the skin, and this is where you have a swimmer's itch. That's where you develop swimmer's itch because of the penetration and the antigenic properties of the Saccharia as they penetrate the skin. Once they enter the skin, they lose tails during the penetration and they become schistosomal. The schistosomal now enter into the circulation, migrate to the portal blood in liver, and they mature into adults. Once they mature into adults,
Dr. Zuriel, you have muted yourself. Sorry.
sorry, have you unmuted me? Thank you.
Yes, you
So
are.
we had circulation, we migrate to portal blood in liver, and they mature into adults. I know you remember how they couple. Usually the female builds a house for the male to dwell, or is it the opposite? At pairing now, stage 10, you have paired adult worms migrate to the mesenteric venules of the bowel or rectum, laying eggs that circulate to the liver and shed. It's also shed into stool. They also migrate for hematobium to the venous plexus of the urinary bladder. From the host now, then you have the process beginning again when the eggs are laid into water bodies. So that is a life cycle, and they cause different disease processes. So you have the GIT disease and genitourinary disease. It's a picture of the dark colored female within the gynecophoric canal, which is a house made by the male for the female to inhabit or cohabit. Again, you see there, you see the female, you see the male, you see the ventral suckers and the oral suckers. You're able to see now the canal, the groove where the female resides. I hope the guys, you got the clue. You got to build a house before you engage on other businesses. Schistosomiasis is considered by WHO as the second most socioeconomically devastating parasitic disease. That is only after malaria, with hundreds of millions infected globally. More than 207 million people, 85% of who live in Africa are infected with schistosomiasis. So here is where we have the burden of disease. and an estimated 700 million people are at risk of infection. We look at the hosts. We have snails, which are the intermediate hosts. One, we have Biomphallaria for Schistosoma mansoni. We have Ongomelania for Schistosoma japonicum. You have the Pullinas for Hematobium. So here we have Biomphallaria species. We have the Bullinas species. We have the Bullinas species. Okay. Again, it's just a refresher on the life cycle. We have the eggs taken up by the snails, Saccharia, penetration, lose a tail, go to the liver, then mesenteric veins, then down to the colon, rectum, and the urinary bladder. There's a confusion there, as you can see. We have terminal spine, which is wrong. Terminal spine usually for hematobium. Apologies for my misrepresentation, while the lateral spine is mansoni, and that's how you recognize them. These are the Saccharia. Then we go to the pathology now. The most serious damage is done by the eggs. Colon, the liver are the most seriously tissues or organs involved. In the liver, you have soluble egg antigen, which causes eosinophilic infiltration. You have an eosinophilic granuloma and abscess formation, and then fibrosis. In the liver, we usually get pipe stem fibrosis. Usually get pipe stem fibrosis. The complications here would be portal vein hypertension. We have esophageal varices, splenomegaly, ascites. You can have hemorrhoids and also varicosities within the umbilicus. We call it caput medusae. It's just showing the lobule and how the liver will appear. See whether we have better histology. There you have the you have the egg. This is the egg. The lateral spine must be here. This is another egg. Now you have surrounding chronic inflammation with eosinophils. The eggs are launched within the ducts, biliary ducts. Once they're launched within the circulation, they're launched within the portal system. In the circulation, you have inflammation and fibrosis will follow up. With time, of course, the eggs or the organisms might die, or they may migrate, but you already have chronic damage to that. So you have the egg, you have the pipe stem fibrosis, round and round and round with a lot of eosinophils. This is the bulk of the pathology. So we see the pathology in the liver. Basically, you have microabscesses around, eosinophil microabscesses around the eggs, and also you have pipe stem fibrosis, leading to complications, which you have seen the complications now will be leading to portal hypertension due to that blockage. Portal hypertension with clinical manifestations, splenomegaly, esophageal varices, and caput medusa with ascites. Now, in the colon, we have also the same thing, eosinophil infiltration. So every time you look at a biopsy and you're seeing marked eosinophilia, then you think of schistosomiasis. You can see, also you can find a granuloma, which is eosinophilic. You have ulceration of the colon with subsequent either fibrosis from the ulcer, or you can also have a polyp. And when you look at the inflammatory polyp, when you look at the center, you find actually it's not malignant, but it's a polyp containing the eggs, particularly Mansoni. So there you are, you have a polyp. This is inflammatory, there's no atypia, and multiple eggs within the polyp. These are the calcified, dark colored polyps. No, not polyps, but eggs. So what are the clinical manifestations? We have an initial stage. At the saccharial stage, you have saccharial dermatitis that appears like petechiae and rashes. So you have petechiae and rashes, then followed by fever, a dry cough due to a pneumonitis. You have an urticaria due to adolescent migration following. That is the initial phase. Then in acute stage, you have the characteristics. Symptoms, the characteristic symptom is dysentery. So you have bloody diarrhea. The patient may pass stool with blood, pus, and mucus 5 to 10 times per day. And this one is laden with many eggs. The patient may also have chills, fever, and malaise. And we say the patient has malaria. So we miss the opportunity to examine the stool using stool concentration method and be able to see the eggs. Now, what happens when you have the adult worms? The mechanical and toxic effects of adults and their metabolites cause mesenteric phlebitis, hepatitis, and abdominal pain. The immune complex may cause a damage to the kidney. We have cystosomiasis nephritis, which results from a type 2 allergy and the eosinophilia. So you have effect on the kidney, mesenteric hepatitis, mesenteric phlebitis, hepatitis, and abdominal pain. So the patient may present actually with urinary complications. We have a chronic stage characterized by manifestation of the patient's interval diarrhea or dysentery, slow deterioration of health, and concomitant chronic liver disease. Terminal stage is characterized by portal vein hypertension syndrome, which we know. You may have ectopic lesions in the central nervous system, either the brain or the spinal cord, which may cause paralysis, monoplegia, or hemiplegia. So you have those from the initial stage to the early. From early, you come to the chronic, go to terminal. And then number 5, not 6, should be the ectopic lesions. Diagnostic protocols, stool examination, direct fecal smear in the acute stage, you're going to be able to see them, or you can do just the concentration test, which gives you the best yield. Biopsy can be done by proctoscope at the terminal stage. Immunological tests are not routine, but they can be done for reference only, or when you're doing your study and your publication. Now, can I have some reactions? GIT tuberculosis. Tuberculosis of the abdomen is a condition in which there is tuberculous infection of the peritoneum or other organs in the abdomen. Epidemiology, extrapulmonary tuberculosis represents about 28% of all reported cases of tuberculosis. GIT-TB was the second most common type, or is the second most common type of TB after pulmonary. You have GIT, then you have other like Nodule disease. Several forms of extrapulmonary TB lack any of the localizing symptoms and signs. So quite non-specific. You may have cutaneous allergy to PPD, and that is when you do the purified protein derivative for MAN2 testing. And there is no obvious clinical or radiologic evidence of pulmonary TB that was picked in a study in a third of the subjects. So nothing is clear clinically that can tell you, think of TB. Pyrexia or fever of unknown origin, non-specific abdominal pain, negative endoscopy findings in majority of the cases. And TB can involve any part of the GIT, from the mouth to the anus. It can be peritoneal, and it can also be pancreatobiliary. There is the pattern of presentation is varied. We know there is a close relationship between HIV and TB. Before the era of HIV infection, 80% of TB was confined to the lung, and extrapulmonary TB is noted to increase with HIV. 40 to 60% of TB in HIV positive patients is extrapulmonary. So there's a close relationship with an increase in extrapulmonary TB with increase in HIV in the population. Mechanisms of infectivity or infection. One is hematogenous spread from a primary lung focus. Number two, ingestion of bacilli in sputum from a pulmonary focus. You can have direct spread, organs, and also you can have lymphatic spread from infected lymph nodes. The bacteria, we know they are gram-negative bacilli, Mycobacterium, Mycobacterium tuberculosis. They are rods. So we go to presentation, acute phase, acute tuberculous peritonitis, acute abdomen. Patients present with acute abdomen with severe pain. And this is because there's acute inflammation of the peritoneum. There is a form of ascites where you have a straw-colored fluid in the early phases. Then you have development of tubercles in the omentum and the peritoneum. The tubercles may cacheate now, and especially when you start the patient with chronic tuberculous peritonitis. We're going to be discussing peritonitis, then we go again to the tract. Patients again will have persistent abdominal pain. They'll have fever, loss of weight, develop ascites and nitrates, and there could be palpable abdominal masses. In peritonitis, the origin of the infection is tuberculous mesenteric nodes. It could be from the ileocecal region, and this is a region where you have abundance of lymphoid tissue. Could be from the fallopian tubes in women, pyosaptings, and bloodborne infection from TB from other primary areas like miliary TB. Miliary because largely it's arterial spread. Now, what are the varieties of tuberculosis or types of tuberculous peritonitis? One, acidic form. And this is where you have peritoneal fluid, distension of the abdomen. Patient comes with a complaint of swelling of the abdomen. There's increased abdominal pressure, umbilical hernia or inguinal hernias due to the ascites. So this is the fluid or liquid type. You'll have the purulent form. The purulent form is rare, but usually secondary to tuberculous salpingitis. You have pockets of adherent intestines and omentum containing tuberculous pus. Basically, you have cold abscesses within the abdomen. You can have the encysted form. This inflammation and ascites are confined to one part of the abdominal cavity. Yeah, you can find it subphrenic on the right or the left. You can find it loculated in one area. Then you have a fibrous pattern, and the fibrous form, you basically have widespread adhesions, adhesive obstruction. Now, we look at those are the patterns, and you need to remember them. You need to remember them. Don't forget this page. This page contains your 14 marks or 12 and a half marks of a short essay. The variants of tuberculous peritonitis. You need to remember the acidic form, the purulent form, and how it comes by the encysted form and the fibrous form. Now, the tract itself, we have the ileothecum and the colon. The ileocecal region is the most common because of the Peyer's patches. We have increased physiological stasis. Increased physiological stasis there because of the valve, ileocecal valve. So, and that's where now there's maximum absorption of nutritional material. There's increased rate of fluid and electrolyte absorption. In this place, and there's minimal digestive activity, and there's abundance of lymphoid tissue. All these together increase the risk. What are the pathologic features? How does it look like? We have the presentation. It could be an ulcer, it could be hypertrophic mucosa, it could be a combination of ulcer and hypertrophy of the lining. These are the features that are seen at endoscopy. Distribution of tuberculous lesions in the GI. They are commonest at the ileocecal region. Then you have the ascending colon, the jejunum, the appendix, sigmoid, rectum, and duodenum. So they are quite rare as you go beyond the ileum. The stomach and the esophagus are also very rare. You can have multiple sites infected or affected in one patient. More clinical features is that it's mainly a disease of young adults. 2/3 of the patients are 21 to 40-year-olds, and the sex incidence is equal both male and female, with a slight preponderance for female. Clinical presentation, you have acute, chronic, acute, and chronic, or subacute. So the patients may present acute, chronic, or recurrent. That is acute or chronic. They present with constitutional symptoms, that is mainly fever, weight loss, anorexia, and malaise. So when you're investigating a patient who has persistent fever, loss of weight, anorexia, malaise, think of TB and think of GIT involvement. They have pain, abdominal pain, could be continuous, dull, or could be colicky pain due to peristalsis. Patients will have diarrhea in a good number, 10 to 20%, or constipation. Majority will also have alternating diarrhea and constipation. So esophageal tuberculosis, this one is quite rare, just 0.2 of the GI cases. By extension from adjacent, usually these patients develop this as an extension from adjacent lymph nodes. Patients were presented with low-grade fever, dysphagia or dinophagia, and or a mid-esophageal ulcer, and it may mimic carcinoma of the esophagus as endoscopy. Gastroduodenal basically affect the stomach and the duodenum, each at about 1% of total GI cases. Mimics peptic ulcer disease. There's a short history and non-response to treatment of peptic ulcer disease. Duodenal obstruction, you have extrinsic compression by tuberculous lymph nodes. The patients may also present with hematemesis, perforation, fistulae, obstructive jaundice, and chest X-ray usually is normal. At endoscopy, you're going to find an ulcer, features are quite non-specific, but you need to take a deep biopsy at the ulcer margin so that we can be able to see the inflammatory pattern and document the presence of granulomas. Ileocecal tuberculosis. Patients present with colicky abdominal pain. Remember, we've seen that's where there is a lot of slowing of movement. There's a ball of wind rolling in the abdomen where it can be visualized with peristalsis. Right iliac fossa lump due to the stricture formation. When you have stricture formation, then you have very slow movement of fecal matter, that area. It can also be mesenteric fat and lymph nodes at that point. Segmental or isolated colonic sections. That is involvement of the colon without involvement of the ileocecal valve. This could be 9.2% of all cases. You have multifocal involvement in a third, and median symptoms duration is less than 1 year. Patients will present with predominant pain, majority of them, due to narrowing of the lumen. So every time there's movement of fecal material, there's a lot of pain. They may have hematochezia in a third, usually minor. And overall, TB accounts for 4% of the low GI bleeding. Other features include fever, general features of TB, fever, anorexia, weight loss, and change in bowel habits that you may see in even in carcinoma, colorectal carcinoma. But here you do not have, in colorectal carcinoma, you don't have the fever. Rectal and anal disease. Patients will have hematochezia, which is the most common symptom due to mucosal trauma by the stool. And then you have the other constitutional symptoms you've seen, including constipation and the formation of a stricture. Anal fistula may also present. Complications of GI TB, you have bleeding, obstruction, because it's a tube, operation, and malabsorption, particularly when it involves the intestine. What are the investigations that are critical? One is routine blood checkup, where you're going to find anemia of chronic disease, a little bit of lymphocytosis. Then you do Mantoux test. This is very practical for that reason, because the patients do not have and may not have pulmonary disease. If the patient has ascites, you collect the fluid and you do cytology and microbiology. Radiology, here we are thinking of ultrasound and or CT abdomen. Endoscope and biopsy. So you do endoscopy, isolate and identify the lesion. We say it could be ulcerative or hypertrophic or ulcerative hypertrophic. If you have not landed a good biopsy and you don't have diagnosis yet, you can do diagnostic laparoscopy, where you put your scopes, you go in, you see whether there are any tubercles. Any tubercles on the peritoneum for peritonitis, or any other lesions that you can collect, and you pick samples from the exploratory laparoscopy. So we've identified it's in the ileum and ileocecal, terminal ileum and ileocecal area. So when scopes are done, colonoscopy, we have mucosal nodules and ulcers. The nodules are variable in size, 2 to 6 millimeters, the most common in the cecum, where the ileocecal, especially near the ileocecal valve. Tuberculous ulcers, these are large, 10 to 20 millimeter, or they could be small, 3 to 5 millimeter. They're located between the nodules. They could be single or multiple. Transverse oriented circumferential, contrast to Crohn's ulcers, and they heal with stricture formation. So these are transverse oriented. In Crohn's, they are longitudinal. And they heal with strictures. That's why patients present with constipation, because of stricture formation. So here we have the nodule, plastic pairs patches, biopsy has been taken, and there we have the biopsy. You have the ulcer that is healing, There you have the scar. You have the earth margin here with tuberculosis or granulomas right here. So microscopy, intestinal TB, the granulomas are large, multiple, they could be confluent, and there is caseous necrosis. Ulcers are lined by epithelioid histiocytes at microscopy. As opposed to Crohn's disease, the ulcers are fissuring. You find lymphoid aggregates at microscopy with transmural inflammation and infrequent small non-caseating granulomas. So in TB, you have caseating granulomas, and in Crohn's, they are not. So this is a classic granuloma as we saw it, we know it. We have giant cells and epithelioid cells here, and a rim of plasma cells. Differential diagnosis: Crohn's disease, malignancy, lymphoma, and chronic colitis. So here is where you ask what else could present like what I've seen. Okay. I know I've finished quickly, but that is what I had planned to share with you. We have ischemic bowel disease pending, and you will do your homework as I also do the rest. TB, have we covered pulmonary? Have we done the chest? Not yet. We're going to cover TB more as we cover pulmonary disease. So for now, if there are questions, I'll answer. If there are none, then I'll allow you to go and do ischemic bowel disease as part of your homework. Thank you very much.
Thank you.
The question is, what is the site of pain in GIT? The pain in GIT depends on where the disease is. Let's assume it's gastric, it will be in that region of the epigastric. If it's the ileocecal valve, it will present as an appendicitis. The pain varies in intensity with the degree of disease. So if this stricture is and it's constricting, then the pain will be more. The patient will have actually intermittent intestinal obstruction, features of intestinal obstruction, because fecal matter will be obstructed from passing through. If it's just an ulcer, they will have pain once the feces are going through or stool is passing through that region due to the friction. If it's in the anorectal region, then you'll have pain in that region too. Colicky pain many times is also referred, so you may find it at different locations in the abdomen. And if the patient has peritonitis, TB peritonitis, then they are going to experience diffuse pain over the whole of the abdomen, particularly to touch or any pressure, they will have a lot of pain on the whole of the abdomen. So that is the nature of the pain that the patient experiences. Khan and everyone else. Any reaction?
I think those are all the questions, Doctor.
All right. Thank you very much.
Thank you. Yes, thank you for your time this afternoon. Wish you a good evening.
Okay, have a great evening.